Hello, everyone. Welcome back to Probing the Literature, the joint journal club between AEUS and ACEP. Today, we have two fantastic author groups. Megan Leo and Jack Tsintolas are here with us to discuss their papers from their respective institutions. Um, our topic today is artificial intelligence and its intersection with ultrasound. We're going to hear about two different articles, and I think we'll have some pretty robust discussion about both of them and the interplay of working with different suppliers, different fields that we're probably not used to with, computer science and those specialists. And I think we're going to have a great discussion and do a lot of learning. So without any further ado, I'm going to hand things over to Dr. Megan Leo, who's going to start up with her slides. Thank you very much for being with us, both of you.
Great. All right. Thanks for having me. Let me pull this up. So I'm Megan Leo. I'm currently at Boston Medical Center, which is a Boston University School of Medicine. I'm currently the medical director of quality patient safety, but the former ultrasound section director at BMC and the upcoming SCUF president. So that's kind of my current activities. But yeah, thank you for inviting me to share my involvement in this pretty cool project. So the manuscript is using deep learning to detect presence and location of hemoperitoneum in the FAST exam in adults. I'll go into a little bit later sort of how I got involved in this project. I think there's probably quite a variety of ways that some of our colleagues have gotten involved with industry, and as many of you have seen at a lot of the conferences, AI is definitely a hot topic right now, especially in point of care ultrasound. Certainly has the potential to bridge the gap for the novice users and potentially improve accuracy. So the inspiration for this project came from bridging the gap for novice users of the FAST exam in resource limited settings and military situations. This was an NIH-funded project, a small business innovations research grant, which I'll go into a little bit later. So the idea was, how can we develop an algorithm that can assist in interpretation of FAST exams in these rural areas where you may have pretty novice users or non-physicians such as military medics, or in a lot of resource limited settings across the globe. There's sort of health health providers that are really kind of local locals that just like kind of serve as the bridge between a rural village and getting to a medical center. So that was the initial inspiration. And this project started quite a while ago. I think it was 2014 was when we had started it. So it's taken a while to sort of manifest, and I'll go through that a little bit more in the future. So basically my role was sort of the bridge between a biotech company local to me in Boston, where they're based out of Newton, Mass, called Biosensix LLC. I was the bridge to providing the clinical expertise, but then also the FAST images. And for this particular development of the AI program, we were focusing on the right upper quadrant views. As many of you know, right upper quadrant tends to be the most sensitive area for free fluid in most cases, most trauma cases. So that was where we sort of focused our energy initially. And the thing that was a little bit unique about our research and our project as compared to others is we were really just looking for trauma-related peritoneum, as opposed to a lot of the other publications that have used other etiologies for free fluid, such as peritoneal dialysis or CIDs, etc. So in the initial stages, we're establishing the ground truths, which was sort of the meat of the work that I had to do. It was in the initial pilot project, which is a different manuscript, we had to do mapping of the positives. So actually like drawing out where the positives were, which is pretty tedious and time consuming. And then with this technology, we were using a different algorithm that was actually using bounding boxes. And I'll show you examples of this. But some of the challenges were, we looked through our archive, and we're, big level on trauma center, pretty robust ultrasound program. I was using a data set that when I initially took over as a director, we were using Osirix to archive our images. So we had a whole database of cases through that system, and then also had transitioned to QPath in 2017. So we were pulling images from both of those archives. And at the end of the day, we were only able to get 44 true positives that we could like link to charts, confirmed that they were actually trauma cases. We had 21 male positives that were true trauma. The female cases that were positive were much, much lower. So we ended up actually altering our methods and also including female patients who had positive FAST from ruptured ectopic pregnancy and ovarian cysts. So that is one of the limitations to our case in regards to mechanism, but those were, kind of still along the theme of true hemoperitoneum patients that we were using. And then, some of the other challenges is, as you can imagine, in a sick trauma case, a lot of us as ultrasound leaders are always nailing in to, capture images, reconcile the patient information, get things like, documented properly. But a lot of these cases these are the sickest patients. If you have a positive FAST in the trauma room, there's a lot of tension, a lot of anxiety in regards to getting the information. Even pushing the save button is sometimes a lot to ask, it seems. So I think that's a very reasonable explanation for why this was so hard, because we had a lot of positive cases in our archive, but a lot of them were like temp IDs or just like non-traceable patients. We went a step further and actually utilized our trauma registry. So I had to loop in our trauma surgery group because they maintain that registry. And so we were able to link several of the positive cases to patients by using date and time and circumstances on the images, and then the case records that actually stated positive FAST. So we felt pretty confident that that was a reasonable way to link some of those. And it wasn't a lot of cases. I'd say it was maybe like 10 of the total positive cases, but then again, a substantial amount that we had to really do that legwork to get the positive. So our total data set was 94 cases, 44 positive, and then the 50 negatives clearly is not as difficult of an ask. So we have lots of those. So I'm not going to be able to provide a lot of technical explanation. This was the figure that we included in our manuscript that on the biosensic side to kind of explain the algorithm, but essentially we used an algorithm called YOLO v3. The advantages of this algorithm, as opposed to what we had used in our pilot manuscript, which was MATLAB, was that this could provide the location of the hemoperitoneum, which I felt clinically was important because, we're already going to be relying on an algorithm to give us sort of a prediction of positive FAST, but then being able to see on the screen where the algorithm was telling us there was free fluid, it gives the opportunity for the clinician to sort of overread that image. And so it's kind of akin to an EKG read. You see what the algorithm is telling you is on the EKG, but as a physician, you're going to have the opportunity to actually read the EKG and determine if what the read is saying is correct or not. So that was sort of the advantage that we spoke through, and this really seemed like something that would set us apart from other algorithms. So the way the algorithm works is the 94 cases were partitioned into a training cohort, and that was 72% of those total cases. So that was to train up the algorithm. And then a smaller portion, just 8%, was used for validation. And then we used 20% of the cases to actually test the algorithm on, and that's where the results and the data comes from. The other thing that the algorithm did was on some of these, and I'll show you more examples, there would be multiple areas of interest that were like tagged as possible, positive regions, and then it would give you a confidence score in regards to how sure the algorithm was that this was positive. So they were able to train it to, in those multiple areas it was suspecting, just take the highest confidence score to use to determine the final diagnosis, with the hopes of reducing the number of false positives and false negatives. The other consideration that we had was in deciding where to err on the side of slightly more false positives versus slightly more false negatives. We chose to choose the path that would give us the least number of false positives, because as you can imagine, clinically, the algorithm telling you there's a positive when it's actually negative, could determine the patient going to the OR and having neck slap, as opposed to having a more false negatives. Clinically, that seemed more appropriate because you have your clinical context, you have and depending on where you are, you have the option of additional imaging to determine if there's true injury or not. So here are our results. It was actually pretty encouraging, with a 95% sensitivity, 94 specificity, 94% accuracy. And then the strength and localization was quite good as well. The other thing that was standout versus some of the other algorithms and AI publications in the literature was that the latency time for processing these images was twice as fast as anything else that had been published. So 57 milliseconds. It's essentially it's equivalent to 18 ultrasound images per second. So still probably it would take, I would say, if you say in one video clip maybe there's like 100 images, let's just say, you're still going to be waiting about 10 seconds or so to get your results. So you could argue whether that's acceptable or not, and 10 seconds seems like a long time in a trauma, but it still was better than some of the other publications that were out there. The two examples here are showing you an example of figure 6. There was a pretty high accuracy or confidence, sorry, on this particular image versus the one on the bottom, where the image on the left with the 1.0, that's our ground truth. So that was the expert interpretation and bounding box that the two of us as reviewers placed on the image. And then the one on the right is what the algorithm localized as positive, and then also the confidence and predictability score. So the one on the top, it's at a range of 0 to 1. So 1 being the most confident. So the one on the top you can see is 0.7, so quite strong. And notable in this image is there's a lot more contrast between the landmarks in that one. On the bottom, the algorithm still predicted the positive fast, but you can see its prediction confidence was a bit lower at 1.4. But and this was another example of where it was challenging for the algorithm to fully interpret this image, and it provided multiple bounding boxes where it thought maybe it was positive, but it would choose and display its highest prediction value there. I just wanted to show also in the manuscript we were just wanting to display the two false negatives that we had. So you can see some of the issues were at play. I mean, this I think can be relatable to any of us as operators, and when you're doing a fast exam. The one on the figure 10, it seems certainly is seems pretty obvious to the human eye that this was positive, but the lack of contrast between the two landmarks was what made that one come up as a false negative. And then you can see figure 11 as well, right where the area of free fluid was, there was a rib shadow that was coming through that area, and that's what we predict was the reason for the false negative. But you can relate that this is, you know, probably often a common pitfall for human interpreters as well. And again, I think notable that the you know, if you have a false negative in a stable patient, they're going to get scanned anyway. If somebody's unstable and it's a false negative, probably you'll do another scan. This figure here was just to show you the different algorithms. I thought it was just interesting to show how some of these different methods are masking and showing the positives. So this is the YOLO V3, which we use. So this one is a pretty high prediction here. And this is how the masking would happen. And to train these type of algorithms, which is what we did with our first pilot project, you know, the ground truth or expert person has to actually with a trace pad, like kind of draw these things out. So it's pretty time consuming. That was another factor for choosing this algorithm as well, is that, you know, the significance of tracing this precisely versus providing a bounding box in a clinical scenario seems you know, unimportant, whereas the benefits of processing these a lot faster, we chose to go with the bounding boxes. So in conclusion, in this study, it's exciting that you know, AI in general can potentially bridge the gap for novice users in a variety of settings. I think the novel aspects of our study was, you know, we did use a data set of all true hemoperitoneum, mostly trauma. Again, our female patients, we had to supplement a bit with hemoperitoneum from gyne sources. It was accurate interpretation, seemed to be equal or superior to the other systems in the literature. And then offering the location of the positive results, I think is a unique add. And again, allows the even the novice user to be able to look at the area that the algorithm is identifying and sort of do that overread, similar to an EKG read. It provided rapid results. And then again, this is a laptop-based algorithm at the moment. So this could be you know, used in any variety of ultrasound machines, which is also very conducive for resource limited settings and military settings, and across a lot of platforms where we're, you know, using different both cart-based, but also in a lot of these settings, we're using a variety of handheld ultrasounds. So as long as there's a way to export the image to the either laptop or smartphone or whatever device that's going to be running the algorithm, this is feasible. So whether it's hardwired, whether it's you know, through an internet-based or potentially even like a Bluetooth type thing, we're not quite at that stage of how to fully offer this or roll it out. But and then I just wanted to kind of open it up. I don't know if people have questions in regards to this, but it's how to get involved. I'll say in my particular scenario, this was sort of like it kind of fell in my lap in a lucky way, I'll say. So my former resident's husband was involved. It was a partner at the Biosensics bioengineering company, and wanted to do a project with his wife, and he was going to be applying for a small business grant, trying to find funding, and they came up with this project together. Now, within a couple of years, my resident graduated. Her husband ended up moving on to a different company, but I continued to work with Biosensics, and through this whole manuscript, I'd been working with a whole different team. But the idea was great, and it's really, I think there's two ways probably to get involved in this kind of like industry-based research. My way was sort of reaching out through the to sort of be the consultant almost in a way to the bioengineering company. The perks of that are you know, their whole like business model is to try to write grants and get funding and generate money basically. So they did all the NIH, application prep, a lot of the assistance in getting our IRB sorted out and funding and communication with our like grants people. It makes it much more feasible for like a person who's not a big researcher, I'll say. I think as somebody who maybe has an idea, and I would say probably the best way to go about it, at least in my mind, would be potentially to scan the literature, see what companies are maybe publishing on your area of interest, and try reaching out to them if you, and that's one way potentially. On the flip side, I had a colleague, Joe Perry, shout out to him, very hard worker, great researcher, who actually wrote up his own grant and then found his partner through MIT to do his research. So that is certainly an avenue as well, but certainly a much harder and respectable route, I would say. But it's been a great experience. We're right now waiting on the decision on an additional grant funding to go ahead and finish off the left upper quadrant pelvic views. We've already done the study on the cardiac views, which is also published. So we'll see where it goes from there. And then the ultimate goal is to, market this. As far as I know, I don't believe I will see any sort of monetary benefit from this. There are ways to negotiate that as well, which I don't know a lot about, but there are different avenues to try to actually like have some proprietary, like, stake in their final product. For me, this felt like an effort that was feasible for me, and I felt like whatever came out of it, this was advancing my career, and this was like great experience. So that was the route that I took. But there's a lot more discussions that go into that. And if you are in that position, I would just encourage you to really talk to your institutional IRB and also legal, and just make sure that you've really talked through that with your institution. Because if you're at an academic place, in a way, they own your some of your stake in these things, in which they are going to be collecting money on your behalf and not you, and so that you really do have to involve them. It's really hard to do this kind of thing like outside of disclosing it to your institution.
Yeah, it sounds like it's a real team effort there. That's fantastic. I love that point about, leveraging the tech company to do a lot of that background paperwork and grant writing, because that's the part I think that scares away most researchers. So I'm going to open the floor for questions and discussion.
So I saw Nick unmuted, so I'm going to let him go first, because my questions are unfrozen caveman lawyer level questions. That reference lets you know how bad these questions are going to be because of all that. So I have some very basic ones. I'm going to let Nick ask a smarter question, and then I'm going to jump in for someone to explain this to me, because I really enjoyed this. I really enjoyed this, but I literally wrote down, okay, references 33 to 42. I'm going to have to look up because I have no idea what's happening in this in the algorithmic part of the study. But go ahead, Nick.
Oh, I don't know that my question is much smarter than yours. I work on very similar projects with companies, and one of the things that I found as a big kind of barrier and facilitator is how to communicate with engineers who have no clinical background. Can you talk a little bit about if you've had challenges with that, if you find, like the engineers that I work with are actually in your neck of the woods, and so we're like 3 hours off all the time, and so all our meetings are online except when we can find each other in conferences. Can you talk a little bit about like how often you meet with them, how those conversations go, how you kind of redirect the clinical value? Like just the concept of specificity over sensitivity alone has been something that we've been really trying to nail home, of like point of care ultrasound, an algorithm really needs to be sure that it's right, even if it misses some things. And they're like, but then our F1 score goes down and that makes us feel sad. So
right. Yeah, I mean, I can only speak to the experience that I've had, with biosensics, and I can hear you because a lot of my, colleagues in various forms are working with, industry that's like in very different time zones. So I have somebody who's in California who's collaborating with somebody in the UK, and then to find like a time to have meetings is just really challenging. And like others who are collaborating in China, and it's just like really hard. So yes, I would say I'm pretty lucky that like we're literally down the street from each other. We tend to just meet by Zoom. The CEO of the company did come to ACEP when it was in Boston a couple years ago, just to sort of like get the feel of things, walk through the exhibit hall and stuff. So, and I would say just this particular company has like at least felt very morally responsible. They're involved in a lot of medical device development and across platforms, a lot of like CT imaging stuff, and then uh, some other like um, like device monitoring technology. I think is kind of their big stuff. So they also they have a lot of experience doing medical development. So I think that kind of helps in regards to being able to communicate with them, and honestly, like um, in having the discussions with them in regards to this like balance of sensitivity versus specificity, and also like the bounding box thing. Like, I mean, they were really open to they seem to have enough clinical sense of the practicality of it that they were open to feedback. And I think I was lucky in that way. I can really imagine though that if they were not wanting to hear that, as a clinician you would prefer to have a false negative than a lot of false positives, that would be a difficult negotiation. So I think as best as you can, you just like when I'm trying to do research with my like statisticians, I'm trying to understand their language, and it's really hard. And probably the same, like they're researchers, and they if is a lot of it's probably personality too. I mean, it's finding the right partner. If they're not willing to like really work with you on this like clinical context, I think I could see that being really, really challenging. So yeah, I appreciate that question a lot. Just in that, like, how do we bridge the two goals of each party, and how do we speak each other's language when we speak very different languages? It's can be tough. Yeah.
Awesome. I know, Andrew, you wanted to have a few more questions. I'm going to let Jack do his presentation. And Megan, are you able to stay on the call during his presentation, or are we going to be bidding you adieu?
I can say, yeah.
That'd be
I'll stay
wonderful.
on as long as I can. Yep.
Great. Thank you so much for doing that. We'll have a joint kind of question and discussion section at the end, in the final 10 minutes. And then we'll have an open forum for the following hour on any kind of questions or projects that people have for our methods consult. All right, Jack, thank you very much for being here.
All right. Hello, everyone. My name is Jack Tsintolas. I'm a fourth-year medical student at Rush Medical College in Chicago. I'm currently on my EM rotation here, and I have a strong interest in emergency medicine. And with step 2 recently behind me, I'm excited to begin the residency application process soon. So today, I'll be discussing our study titled Comparison of Artificial Intelligence versus real-time physician assessment of pulmonary lung edema with lung ultrasound. So before we dive into the details, I want to acknowledge the team effort behind this research of Dr. Gottlieb, Dr. Patel, Miranda, Dr. Pesca, Dr. Beilitz. The study was supported by the Society of American Academic Emergency Medicine and the Academy of Emergency Ultrasound Research Grant. We have no conflicts of interest. And then there's a QR code to the right that links to the journal article and the PubMed ID for reference as well. So dyspnea, shortness of breath, common reason for patients to present to the ED, accounting for nearly 5 million visits in 2020 alone. There's many potential causes of acute dyspnea, including heart failure, asthma, COPD, or pulmonary embolism. Acute decompensated heart failure is a frequent cause, requiring prompt and accurate diagnosis to initiate targeted interventions aimed at reducing morbidity and mortality. and diagnosing pulmonary edema clinically can be challenging due to a lot of symptom overlap with other conditions. So, as previously mentioned, acute decompensated heart failure requires prompt and accurate diagnosis. Traditional methods, including taking a history, physical exam, x-rays, often can lack diagnostic accuracy. In this context, thoracic point-of-care ultrasound may be a superior tool. POCUS can identify pulmonary edema by the presence of B-lines, which are discrete vertical hyperechoic artifacts extending from the pleural line to the bottom of the ultrasound screen. And the presence of 3 or more B-lines between 2 contiguous ribs may suggest pulmonary edema. This method can improve diagnostic accuracy and reduce the time to diagnosis, making it extremely useful in resource-limited settings and for monitoring response to therapeutic interventions. So here we have a GIF demonstrating B-lines and lung ultrasound. The lines move synchronously with lung sliding, and accurately identifying and interpreting B-lines can significantly enhance their diagnostic accuracy in patients presenting with shortness of breath. So the primary aim of the study was to compare the sensitivity and specificity of lung ultrasound for detecting pulmonary edema using artificial intelligence versus a trained physician sonographer performing this in real time. And as a secondary objective, we compared sensitivity and specificity among patients with low versus high BMIs. So this was a prospective observational study conducted at Rush University Medical Center, which has a busy ED with nearly 70,000 visits annually. It's a quaternary care hospital with a 3-year EM residency program and a clinical ultrasound fellowship. So inclusions, we included adult English-speaking patients suspected of having cardiogenic pulmonary edema, and we excluded patients with symptomatic COVID-19, interstitial lung disease, clinical instability, prior enrollment in the study, declining participation, and if they had no concern for pulmonary edema. So patients were identified by research assistants via convenience sample when the physician sonographer was present from 8 a.m. to 4 p.m. The assistants collected basic demographic information like medical history, age, gender, height, weight before starting the study. And all ultrasound examinations were performed by a new ultrasound fellow trained to the level of the American College of Emergency Physicians Emergency Ultrasound Guidelines. And the fellow received specific training for the study, including a 1-hour session followed by 25 proctored lung ultrasound exams by an expert sonographer. And the ultrasounds were performed using a C1-5 transducer with a 12-zone technique, capturing 6-second video clips from each region. So here is the equipment we used for the study. On the left, we have the transducer from GE Healthcare, which is a convex array transducer useful for abdominal and lung imaging. On the right, we have the venue point of care ultrasound system, also from GE. So the physician sonographer made real-time assessments of the lung fields. If the lung field was positive with 3 greater than or equal to 3 lines, B lines, or a wide dense B line. Meanwhile, a research assistant used the AI software called Auto B lines from GE to retrospectively analyze the same clips with a similar protocol where positive was defined as greater than or equal to 3 B lines or a large dense B line. The physician sonographer was blinded to the AI assessment as well, and lung regions were excluded if they were not adequately visualized. To serve as the gold standard for detecting pulmonary edema, 2 expert sonographers with over 10,000 ultrasound images. Image reviews were blinded to both the initial patient assessment and the AI findings, and they reviewed the clips independently, and then reached a consensus on B-line interpretation. So this image shows application of the AI in assessing pulmonary edema through sonographic imaging in 2 different lung fields. On the left, labeled A, we have the positive lung field showing the presence of B lines. Then on the right side, labeled B, we have negative lung field with no B lines noted. So of the 284 patients approached, 84 were excluded due to no concern for pulmonary edema. 52 had COVID-19, 51 declined participation, 20 did not speak English, 7 had interstitial lung disease, 5 were unstable, 4 were previously enrolled, leading to 71 being included in the study. The mean age of participants was 62, with a little over half being women, and the mean BMI was 33.4. Now, of the 852 potential lung fields, 752 were adequately visualized for analysis. And overall, 36% of these lung fields were positive for pulmonary edema. So in terms of diagnostic accuracy, the results showed that the physician's assessment had a sensitivity of 96.7% and specificity of 79.1 for detecting pulmonary edema. In comparison, AI had a sensitivity of 95.6 and a specificity of 64.1. For our subgroup analysis by BMI, when analyzing the data based on BMI, both the physician and AI assessments were more sensitive in patients with a lower BMI, whereas specificity was higher in patients with a higher BMI. Additionally, the AI demonstrated significantly higher specificity among patients with higher BMI, and these findings indicate that both AI and the real-time physician assessments are highly sensitive for detecting pulmonary edema. However, AI's lower specificity means that it produced more false positives compared to physician. And while AI can be an excellent tool for ruling out pulmonary edema, caution should be used when interpreting positive results. Previous studies have also examined AI's performance in this area. For instance, one study found that AI was highly sensitive but less specific, often overcounting B-lines. In contrast, another study reported that AI tended to undercount B-lines. So our study's results align with the former, reinforcing that the notion of AI's high sensitivity but variable specificity. And AI's higher specificity with a higher BMI, with higher BMI patients may be due to the attenuation of ultrasound waves with greater soft tissue, leading to fewer B-lines. So there's several key strengths of the study. Unlike previous studies, we focus on the clinically relevant measure of positive versus negative lung fields rather than a specific count of B-lines, which can vary significantly. And additionally, our real-time assessment approach closely reflects actual clinical practice. And we excluded COVID-19 patients, ensuring our findings were applicable to non-COVID-19 pulmonary edema cases, as COVID can cause different findings on lung ultrasound. Furthermore, there were some limitations to consider. This was a single center study, which may not be generalizable to other settings. All exams were conducted by a single physician sonographer, aiming to reflect a new attending physician who completed their residency, but received some additional training early in their fellowship. And similarly to what Dr. Leo has said, experience can affect diagnostic performance as well. So furthermore, we use one specific AI software, and our results may not apply to other AI systems or future versions. The AI software analyzed save loops, ensuring the physician and AI analyze the same images, but it did not utilize the AI quality indicator as well. So AI offers consistent and objective assessment of lung fields in resource-limited settings. Access to highly skilled radiologists or sonographers can be a challenge, and AI-powered ultrasound machines can bridge this gap by assisting less experienced healthcare workers in accurately diagnosing pulmonary conditions. And beyond detecting B-lines, AI can perform additional analyses on ultrasound images, such as lung aeration, pleural effusions, and even monitor changes over time. And also, as Dr. Leo said, one of the benefits of AI is it can possess the ability to quickly process and analyze ultrasound images, providing immediate diagnostic information at the bedside. And over time, longitudinal analysis can provide clinicians with more data to adapt therapeutic plans, facilitating better clinical decision-making and personalized treatment plans. So in the future, AI shows promise not only in clinical diagnosis, but also enhancing physician training. Using AI can provide consistent feedback with automated assessments and it can serve as a valuable educational tool, improving the proficiency of clinicians in interpreting ultrasound findings. It's crucial, though, to continue refining the algorithms to enhance their accuracy and specificity, and future research should focus on reducing the false positives and negatives, and thereby increasing the reliability of AI in clinical practice. Furthermore, conducting multi-center studies will help validate our findings across different patient populations and healthcare settings. This ensures that the benefits observed in our study are reproducible and applicable on a broader scale. And moving towards real-time AI applications in clinical settings, I think is essential. Integrating AI into bedside assessments can expedite the diagnostic process, leading to more timely interventions and improved patient outcomes. And then lastly, long-term studies are needed to evaluate the sustained impact of AI on clinical decision-making and patient engagement. So in conclusion, both physician and AI assessments were highly sensitive for detecting pulmonary edema, although physicians were more specific. This implies that AI could be particularly useful in ruling out pulmonary edema, but positive findings should be interpreted with caution, and future research should explore factors that could enhance AI's diagnostic accuracy and validate these findings across different settings and AI platforms. There's my
Great work.
Any questions or anything?
So I just had one quick question because clearly I missed this, and I don't know how I missed it. But the gold standard, was it just like the ICD-10 code on the chart at the time of discharge or admission? Like I missed where the gold standard for comparison was.
So two expert sonographers would review the scan, and then they would reach a consensus, and that consensus would be the standard, whether yes or no.
Okay, thank you. And we'll open up to further questions and discussion.
Any ideas how many other AI softwares are out there, exist out there that can do the same thing?
Off the top of my head, I'm not sure, but I can get back to you.
I think Butterfly has one. I think so. GE obviously has one. I'm not sure about Mindray. I think Philips is working on one in a conjunction with another company called BARDA. So there's at least 3.
Yeah, I think Mindray has one, and Philips has the Lumify has one, but I don't think their cart-based systems have one yet.
Yeah, there's I think a lot of the vendors now are like making sure they have something AI, because they're feeling like that's sort of like the catch to get people, especially the handheld. So I think Echo also, EXO, their new probe that's kind of similar to Butterfly in appearance and whatnot. They have an AI option. Some of it, a lot of it's like geared towards like education stuff as well. Like there's some guidance some of them offer, and there's certainly like a ton of AI research that has not actually hit like industry yet. So it'll be interesting to see where it lands.
Yeah, I would love to see what would happen if they used the AI guidance tool, because they specifically said they didn't use that. It was recorded clips that were at the discretion of the fellow. But if you used the guidance and then analyzed sensitivity specificity of the same population with and without guidance between like a couple of different people, that to me would also be interesting.
Yeah, that could be another future study potentially using the guidance.
Yeah, I mean, I think there's also a lot of potential for like global health education initiatives. Like there's a couple of my colleagues are doing, this funding is so small, so these are just really tough projects to do, but just like tele-ultrasound for various initiatives in South Africa, and then there's another project going on in Namibia, and another colleague's doing one in Nigeria. So it's like bridging the to spend $2,000 to $5,000 to like fly over and stay and do courses, etc. It's sort of that, maybe you have to do one in-person course, kind of a train the trainer situation, and then you can do some tele-ultrasound scan shifts with them, or certainly like the remote QA review. And then maybe incorporating AI into that also could really help, bridge the gap for those places that are really otherwise not going to have any trainers.
I feel like this came up, I can't remember which journal club it was, but I've sort of had the experience where a product was, in particular handhelds, a product was purchased because it had some AI capabilities, but then for this reason of we don't have enough people to sort of supervise, the residents as they're learning. But then we very quickly came up against the image quality issue where, okay, a couple weeks in, everyone gets generally what they should be doing with the, to the extent that the AI can teach them. And now they're just like, well, now I want a better image. And we sort of came up against sort of a device limitation, or we felt it was a device limitation from that point of view. So it was kind of an interesting situation of again, those things when you're trying to purchase a machine, image quality, AI bells and whistles, like what sort of is the best thing for your learning needs. It's kind of an interesting problem that we had.
Yeah, and I wouldn't, kind of like you're alluding to, take it for face value. Like, definitely set up a time to demo it. Really challenge it when you're trying to decide if you're going to purchase it or not, because there's still a lot to be improved upon. And if that's truly the only reason that you're buying a particular product, you really want to make sure it's actually doing what you want it to do.
Makes a lot of sense. Quick question about some method stuff. So we had reviewed a couple of months ago some IVC AI stuff, and they had an interesting population of scans they pulled from social media. So they pulled scans off of Twitter and like the internets from random who knows where. They themselves said, oh, this is the thing we were looking for. And then they used that to train the AI model. Now, you had mentioned you wanted, like, I want this to be hemoperitoneum. I don't want this to be dialysis patients. I don't want this to be ascites patients. I can sort of grasp where that wants, like, why that's important. But if the question is free fluid in the abdomen, maybe this is more of a philosophical question. Does it matter where it came from?
Yeah, so my colleague Jim Feldman is on, who was my mentor, and he has some comments on this because we've had this discussion quite a bit in developing our project. So yeah, Jim, what do you think about that?
Yes, can you hear me? Because I'm outside.
Yeah, we can hear you.
So thanks for the invite. First of all, Megan was the expert in this project, and I was supporting her in the pathway to what hopefully she'll be able to lead as a multi-center study to finalize work on this algorithm and incorporate it into a device. So one of the reasons why this was so challenging for us is because to go to the FDA, you need to go back to source material and document that the patient has the disease that's the target of your diagnosis. So that was why, if you're going to look at use of FAST in a trauma population, you need to look at that population and need to confirm that they had hemoperitoneum. And I also was really surprised, although subsequently looking at the literature and people's experience, this is very challenging because people don't record positive FAST in unstable patients. And then trying to cross-link these was difficult. But the reason was, if you're going to go for device approval, the FDA wants to see that you've actually demonstrated that you have the target condition. There were some philosophical reasons. You all probably, as ultrasound experts, know better than I about, I mean, the amount of fluid you could see in ascites, or potentially the appearance of a liver or spleen in those populations could differ from a young person with traumatic hemoperitoneum. But it was, so that's why we had to do it. The other thing, which also was surprising to me, again, when you go to NIH in the study section, that they actually wanted to have stratified by sex because they argued you need to demonstrate that that hemoperitoneum was similar in appearance regardless of sex, and hence we had to. And when you think about getting traumatic hemopericardium, for example, that can be really difficult, and also there are gender differences in that, the frequency of that occurrence. So, that was why, I mean, outside of the pelvic view, to me, wasn't a lot of rationale, but it was required by the study section, and that's why we had to do that. So, that's a brief comment. I think someone had asked about the gold standard. It's an important question. For example, and I'm just, what is the gold standard for pulmonary edema? This comes up in many studies about how do you know, or which population do you include if you're going to use it clinically in people who have dyspnea, and you may not know ahead of time if they have, some of the exclusion factors. But that was what really was the reason for both the complexity of the study and the population that was selected. Thanks.
I appreciate that insight into like the NIH target condition. That's not something I think I've heard of too many times. So I appreciate that insight.
Yeah, and then this next step that Jim alluded to, as far as the this pending NIH grant application, is to do a multi-centered study to see if our findings, local at Boston Medical Center, can also be seen at other institutions across the country with their archive of traumatic hemoperitoneum. Again, just like along the lines of like getting FDA approval and making this, standard as part of an ultrasound product. So that's sort of the next stage, and we're still waiting to hear whether we get the funding or not, but we're hopeful, and Petra would be one of our colleagues on that, so we're excited about that. So
nice.
It's been a great project to learn from, for sure.
Is there a way that you can like reverse engineer a registry where, like, if you take the trauma registries for like the whole US and then back find, hemoperitoneum, and then find the ultrasound clips from that, and then go to those individual organizations? It would be a lot of work, so you'd need a lot of grant money to do it. But is that a thing? Is there like a version of that somewhere else?
I mean, that's potential. I'll let Jim also comment on this, because he was really the one who kind of brought the idea of like using the trauma registry to really pull these additional cases. Each institution is going to have their own trauma registry, so I don't know that there's like a national registry. So you'd have to, like, each place would have to potentially do that, and then you go back and query the archive, is the image there? So certainly is possible.
Japan.
Just like a lot of
the answer is Japan.
Maybe the answer is AI, and like we let AI screen the whole archive and pull out the positives, and then we kind of go that way. I don't know.
And the machine creates the machine.
Yeah, right. Yep, that's where we're headed, I guess. But yeah, it's a lot of like manual work, because like, as you all know, these traumatic positive FASTs, it's very spotty whether they even get recorded, and certainly whether they're like documented correctly. It's certainly at Boston Medical Center, level 1 trauma center, biggest volume in New England. That was the number that we could come up with. So just to give some perspective on, and it's not a volume issue per se, but it was just really challenging to be able to, link those positive FASTs to a human and be able to actually like report on it. So
yeah, I found that just like with this project that we're working on, but also with Reason, where it was like, oh, there's something that's a standstill, and the timestamp is the same timestamp as the ECG that we have. So that's probably the same person. And then I like reach out to the clinical team and find out, hey, does this look like that heart that you were trying to resuscitate? And they're like, oh yeah, that's totally the one. We just never put the MRN. But if you're searching back like 10 years, you can't very well keep doing that for every single patient.
It takes a lot of energy. So
I'm just going to answer you. I think your concept is a good one. The issues that we had to face were now, because the metadata you had to run, that the images are adequately de-identified, and that required review by the privacy officer. You're working with an industry person, externalizing it, making sure that the linking files are kept locally. But I think conceptually, if people were really interested in it and developing a data set, that had different kinds of images, and particularly across a spectrum of disease, because that to me also is a challenge. If you have large ascites versus trace hemoperitoneum, they're really different questions you're asking of an algorithm, I think. But yeah, it would be helpful to have such a resource available if people ever wanted to think about it.
Yeah, that'd be a great idea. Can I ask what NIH institute you submitted that to?
Jim, I think it's just the SBIR.
Yeah, these were Small Business Innovation Awards.
Oh,
and
gotcha.
the follow-on also was, I think, a similar funding type mechanism. So, yeah. I mean, Megan could provide you with the details if you're interested about the funding pathway and the learning curve for that too, which was pretty interesting.
Yeah, it'd be cool. I mean, I think, one of the things that I am constantly running up against is it seems like everyone and every company and every funding agency is interested in developing the tool, but there's less interest in the stuff that like Jack and Mike were doing of actually validating it, or the kind of thing that Andrew was talking about of like, okay, now we have this tool, where is it useful? How does it need to be designed and output and things like that? And to me, that's kind of the interesting research piece. And I haven't seen a lot of funding announcements for that kind of work. But I feel like, even after it's through the FDA, the validation burden is still so high before anyone actually adopts it.
Or gets FDA approval.
Well, so the FDA approval happens, and then the company is like, sweet, we got our promotion, let's go, but no one's, I don't know that anyone's using the B-line counters. I don't know that anyone's using the auto IVC clinically.
I think one of the big things would probably be the military, because I know they tried to poach a program from us just for training purposes, and then skedaddled with all our materials. So
yeah, no, DoD would be a great like implementation science kind of type of place, because those folks are so motivated to get new tech and understand how to use it.
Well, also they're trying to get all these hyper portables onto critical access situations like, front lines and subs and all these weird places where they don't have like a robust internet connection, and they have to just make decisions. And so the AI software could be a real boon for those situations, because then that decreases the time for them to do all these like teleconsults. So. I think this was absolutely fantastic. I think what we'll do is we'll call it there from a PTL perspective. We're going to move on to the methods consult, and then the probing the literature faculty, if you guys could stay on, I think we may want to have like a quick meeting about next year and some planning questions. So thank you everyone for coming. Thank you, Dr. Leo. Thank you, Jack, for coming. Really appreciate you guys discussing your fantastic work and all the effort you guys put into it, and giving us a lot of those pointers that we can help push the field forward and really obtain excellence. Thank you so much.
Thanks.
Anyone else who wants to discuss any projects they have, feel free to stay on, ask away, or thoughts.
Can I just
questions?
say?
Sure.
Yeah, I just want to thank you, Dan, for being such a great leader and our controller, our system. I always want to say our pilot or our navigator for PTL for the last 2 years. You've done an amazing job. And for those of you not aware, Dan has been promoted, so he is going to be leaving us on PTL, but hopefully we'll be able to get him back in here to at least help out with some small group stuff or whatnot. But I really, really, really appreciate all your help. You've been awesome and amazing. We couldn't have done this without you.
I appreciate it. Thank you so much. Really felt like it was a secretary position and herding the cats.
That's a huge part. Cats are hard to, herd together. So awesome work.
Yeah.
You're so good at it.